All right. Thank you, everyone. I appreciate you being here today. My name is Ashley Christensen. I am a child welfare specialist with Iowa Children's Justice. I have a lot of humility and gratitude today for being invited to the Growing Community Connections presentation to share the work that we get to do at Iowa Children's Justice with efforts towards developing collaborative partnerships through public and private agencies across child welfare in Iowa. Some of our partners are going to be included in the list, but not limited to juvenile court judges, the Department of Health and Human Services, representatives from Public Health, Medicaid, AEA, or the Area Education Agency, Prevent Child Abuse Iowa, substance use disorder agencies, hospitals such as Unity Point and Allen Maternal Health, Unity Point, the Child Advocacy Center and Child Protection Centers, the University of Iowa, Orchard Place, and maternal health representatives, to name a few. I want to extend my gratitude again for Growing Community Connections, for allowing me this time to share the work of Iowa Children's Justice along with our partners, as well as to take a moment to recognize the work of Siouxland Cares and the Siouxland District Health Department and their partners for their progress in advancing identification of pregnant women who may benefit from conversations and interventions around the topic that we'll be discussing. Today, I'll focus on why are the courts involved and how did we get here in talking about pregnant women and their children. Also, what is the data that we're collecting from Iowa Children's Justice with our partners about Iowa's children and pregnant women, including current data around the use of alcohol, illegal substances, tobacco during pregnancy, and finally being able to share some of the resources that have been developed around this area. Okay, so why are the courts involved? So through some efforts that I will discuss in our next slide, Iowa Children's Justice began to see opportunities to ask further questions and explore what's available for women of childbearing age and or pregnant women and later their children who are born, to see what can be done to ensure that awareness and education is made available around the risks of prenatal alcohol and substance use, if that has occurred, and how intervention at the earliest stages of pregnancy can greatly improve developmental outcomes for children. We recognized an immediate opportunity to what I will say is work upstream prior to court involvement through multidisciplinary approaches. So when it's appropriate, we hope to avoid court involvement of children who are exposed to substances prenatally or environmentally and have experienced developmental impacts of substance use, which led us to ask some questions around the need for education and awareness of those risks and the impact of prenatal alcohol and substance exposure, as well as environmental exposure on development of children. We want to help support the work of our partners in avoiding the trauma of removal whenever possible. And then for women of childbearing age and or pregnant women, to decrease the number of children born with substances in their system that has impacted their development, which is, I'm happy to say, a shared goal of the Maternal Health Substance Misuse Committee here in Siouxland. We do this through early identification through the use of a validated screening tool called the 4Ps Plus, which I will talk about in a couple slides. And then how, if that 4Ps Plus screening tool is considered positive, how to offer a brief intervention and connect the patient to appropriate referral sources. Also, to help support getting the message that Dr. Chasnoff, one of our partners, shares consistently and is also consistent with the message of the American College of Obstetricians and Gynecologists, as well as the American Academy of Pediatrics, that is, no amount of alcohol is safe at any point in pregnancy. And what can the work of our partners be to help, again, decrease the number of Iowa children born affected by substances? So how did we get here? Iowa Children's Justice was started through federal funding of court improvement dollars Really, during this, the work of our court improvement project in Iowa Children's Justice, part of the piece that we do through that is court observation, and we began to see patterns of child development impacted potentially by prenatal and or environmental exposure, which led us to the question, are there screenings available to determine if prenatal exposure was a factor in involvement in the court system? And if so, what resources are out there to further screen and evaluate and develop appropriate treatment plannings? We also pursued and were awarded several federal grants to help focus on helping families get well to achieve the permanency goal of reunification, as well as opportunities to work with partners to evaluate needed supports and services to help kids and their families get well and stay well. That led us to the work of bringing the Family Treatment Court model to Iowa. Family Treatment Court is a parallel approach or an integrated approach to the juvenile court system when there is a parental substance use disorder that has impacted parenting, and takes a multidisciplinary collaborative approach to working with parents to help them get well, again, to achieve that goal of reunification. Additional grants that we wrote for and were awarded were to begin the work and continue the work with Dr. Chasnoff, and those grants are listed as the OJJDP grant, RPG 5, so Regional Partnership 5 and 7. And so in 2014, we started with the OJJDP grant, which identified the goals of developing a leadership institute, which pulled together the public and private agencies to support the work of child welfare across the state. The goals of the Leadership Institute include that all pregnant women are screened for alcohol, tobacco, marijuana, and illegal substances, as well as domestic violence and depression, utilizing the 4Ps Plus as a normal component of healthcare throughout our state. The second goal is that all women in prenatal care with evidence of current problems of substance use, depression, domestic violence will receive a brief intervention in that healthcare setting. Next, that all women in prenatal care found to need treatment are referred to that treatment to meet their needs. Fourth is an effective family-centered and or gender-specific treatment services are available for those women in prenatal care who need them. And lastly, to assess and develop a treatment plan for children birth to 5 to address developmental and behavioral disorders related to prenatal or environmental exposure to substance abuse and or trauma. So since the work of the Leadership Institute, we have been collecting data through partners implementing the 4Ps Plus in their clinics or work with pregnant women. Additionally, we have helped support the development of several family resiliency programs, and we'll talk about that data as well as policy implications in just a moment. Locally, I want to share data that's been collected from our birthing hospitals in Siouxland, that in the early 2000s, we were generally seeing about 10 to 20 drug-exposed babies born per year. Since 2015, we've seen the rise of exposed children born in Siouxland to the numbers of 70 to even 90 babies born exposed to substances each year. And so through the work of Dr. Chasnoff, we have begun talking in Siouxland about the use of a 4Ps Plus screening tool. And just to share some of the findings of his research study, one research study of 1,500 women were administered the 4Ps Plus screening tool, as well as urine toxicology in their prenatal visits. Urine toxicology only identified 2% of those 1,500 women in a positive urine toxicology. By providing a 4Ps Plus interview and conversation, 20% of the 1,500 were actually found to be using alcohol or other substances during their pregnancy. I know that there are some folks using meconium toxicology, and Dr. Chasnoff's research shares with us that that's generally only going to identify substances or drugs used in the last trimester of pregnancy. And part of the disadvantage to meconium toxicology is the difficulty of ensuring accurate collection of the meconium, and the results are not readily available. It generally takes about 2 to 3 days to receive those results, and so that is not helpful in an acute situation. So a little bit about the 4Ps Plus. This is a screening instrument that can be used by anyone working with pregnant women, medical providers, home visitors, nurses, in-home providers are the primary partners in Iowa who are using this tool. The 4Ps Plus is the only validated screening tool designed for pregnant women. While there's other screening tools out there, this one is the only one specifically designed for pregnant women across all races to screen for heavy alcohol use, light alcohol use. Again, for the messaging around no amount of alcohol is safe at any point in pregnancy. It also screens for illicit drug use and is gender specific. The 4Ps stands for parents' history, partner history, past history of substance use. Those are introductory health-related questions that have no validity but may inform whether or not necessary referrals are needed. And the last P is for pregnancy. And so these are the questions that are validated and are required to be asked as written. The 4Ps Plus is composed of open-ended questions that produce more honest answers in a normalized fashion. The goal is to identify any woman at risk of using and not necessarily or not at all diagnosing a substance use disorder, as the factors around alcohol use, illicit drug use, depression, domestic violence, and tobacco use are high-risk behaviors for pregnant women. If the pregnant woman has answered yes to any of the validated questions under the pregnancy category, then the provider will follow up with questions or the field assessment that is in the plus part of the 4Ps Plus screening tool. If any of those are identified in needing a brief intervention, Dr. Chasnoff has created a brief intervention that's called I Am Concerned that helps facilitate an ongoing conversation about if continued use or engagement in behaviors continues, what that could be for the development through the pregnancy. So I mentioned in Iowa that we have partners utilizing the 4Ps Plus behavioral health screening. And so far we've collected data on 2,325 women covered by data sharing agreements in the first 6 years of this project. It has been administered at their first prenatal appointment in 55 of the 99 counties throughout Iowa. A total of 2,014 referrals were made in a variety of health and behavioral health services, substance use treatment, mental health, domestic violence programs, tobacco cessation, and home visiting. It is noteworthy that 61.7% of referrals have been accepted by all women. Of particular note, the highest rate of refusal of referral was for tobacco cessation programs, but most women accepted referrals for all other intervention services. In examining the rates of substance use among the 2,325 women, we found that 42% were using at least one substance in the month before they knew they were pregnant. That broke down to 26.6% were using tobacco, 24% using alcohol, 12.5% using marijuana, 6.7% misusing prescription medications, primarily benzodiazepines and narcotics, and 10% were using illicit drugs such as heroin, cocaine, or methamphetamine. Among those 977 women, that 42% with a positive screen, once the women had learned they were pregnant, 30 0.7% of women with a positive screen continued to smoke tobacco, which could be a policy implication and focused efforts. 14.9% continued to use alcohol, 12.9% continued to use marijuana, 8.8% continued to misuse prescription medications, and 8.6% continued to use illicit drugs. In assessing other behavioral health indicators, of the 2,325 women, 18% screened positive for depression and 7% were at risk for domestic violence. It's also important to note here that a lot of the data is collected from home visiting programs. And so we believe that the 7% screening positive for domestic violence could be higher as a result of these screenings being done in their home and may not be in a safe environment to answer honestly. The I Am Concerned pre-treatment curriculum or brief intervention was developed by Dr. Chasnov and Dr. McGurtney in 2002 for the use with all women who screen positive for any factors within the 4Ps plus. Among the women who continued to use substances after knowledge of pregnancy in Iowa, 395 brief interventions were offered and 320 accepted that referral. So when we know that prenatal substance exposure has occurred, we recognize the need in Iowa to have programs and services that could serve those children. And so we initially began work with Blank Star Center in Des Moines, and then helped stand up a family resiliency program through the Waterloo Allen Maternal Health Center, as well as began but had to discontinue efforts in Muscatine. And currently under our Regional Partnership 7 grant, we are working to stand up a similar clinic to the model in Waterloo for their family resiliency program. So the next amount of data will be from those family resiliency programs. So 71 children aged 0 to 5 with a history of prenatal or environmental exposure to substances have received neurodevelopmental assessments in one of the family resiliency programs. 31 of those children were from the North Central Iowa site and 40 were from the Central Iowa site. The child welfare factors regarding child welfare involvement, we found that 59 of the children were court involved. At the time of the initial assessment, 35.2% of the children were living at home, and the same percentage were living in foster care. 18.3% of children were in kinship care, and 11.3% were in adoptive homes. The substance exposure among the 71 children, we found that 35.2% were exposed prenatally to substances, 56.3% were environmentally exposed, and there was an unknown type of exposure that amounted to 8.5%. The total number of substances to which children were known to have been exposed for ranged from 1 to 4. Data on the specific substances were identified for 38 children. The most frequently known substance was methamphetamine. We found rates that followed marijuana found in 16 children, alcohol in 9, opiates in 5 children, exposure to tobacco in 3, cocaine 1, and other was 2. This then breaks down into data around how those substances impacted areas of sensory processing, behavior, adaptive behavior, adverse childhood experiences, and then behavioral regulation. So of the 31 children that we were discussing, we found scores that indicated 28 of those children had scores that were outside the typical range for one or more dimensions of sensory processing. The child behavior checklist was administered on 43 children 18 months and older. Their scores found clinically significant levels on subscales for internalizing behavior, externalizing behavior, and total problems. On the factor of internalizing behaviors, 11.6% of children in the clinical range. On the externalizing behavior, 23.3% of children scored in the clinical range, and on total overall problems, it amounted to 23.3% of children in the clinical range. Regarding the adaptive behavior, generalized adaptive domains of the ABAS was administered on 59 children for ages birth to 5. The ABAS measures the child's capabilities and whether the child uses these capabilities by completing tasks of daily living. This includes adaptive skill areas, conceptual, social, and practical. Based on the norm score of 100, the children's scores ranged from 64 to 120. As it relates to adverse childhood experiences, data regarding the number of adverse childhood experiences were available for 61 children. ACEs ranged from 0 to 11 with a mean score of 5.84 and a standard deviation of 2.14, with a median score of 6 adverse events. 5 children had an ACE score of 10 or 11. Experiencing 4 or more ACEs throughout childhood is associated with increased risk of a host of behavioral or physical health problems in adulthood, according to Felitti in the research he did on adverse childhood experiences in 1998. In the sample of children aged 0 to 5, 90% had already experienced 4 or more ACEs, indicating an extraordinary level of trauma. And the last data that I will share around the family resiliency programs are related to the red flags that Dr. Chasnoff developed and has validated. So the red flags data was available for 62 children in the sample. The total scores range from 0 to 16 and demonstrated wide variation with a mean of 5.35 and a standard deviation of 3.91 with a mean score of 4.5. A red flag score of 3 or more with any one domain, cognitive, self-regulation, adaptive functioning, or a total red flag score of 5 or more is indicative of difficulties with behavioral regulation. In this population, 16% were assessed with 3 or more red flags in the neurocognitive domain, almost 18% in the self-regulation domain, and a little over 14% in adaptive behavior, and 21% in sensory domain. The total red flag score of 5 or more was assessed for 50% of the children that were seen at the family resiliency programs. Some of the achievements that we would like to highlight through this work are raising the awareness across the state and increasing the knowledge and skills in identifying factors and impacts of substances on women who are pregnant and their children. For the women who are pregnant, screenings found significant associations between substance use, depressive symptoms, and domestic violence. The Leadership Institute's success in providing brief interventions and referral services are particularly important for women's health and well-being. Some policy implications that we have found are to further improve interagency communication and collaboration and promoting uniform protocols and patient-informed consents procedures, as well as consistent strategies for expanding maternal and child programs across Iowa while maintaining flexible approaches to meet the community needs, allowing the service to our diverse rural populations. Training programs should not be isolated in their efforts, but continuing with ongoing real-time support and ongoing input and mentoring via telephone or electronic communication methodologies, as well as in-person visits. Knowledge building across the systems is essential for the goals in achieving these efforts statewide. A study was done on the implementation of the Child Abuse Prevention and Treatment Act, also known as CAPTA, across Iowa. And we found that 82% of healthcare, 71% of court professionals were unaware of this legislation, and few knew of the correct markers indicating if an infant had been affected by prenatal substance exposure. And this is research that Dr. Chasnoff did in Iowa in 2018. So for the next steps based on this data, we have been really focused on expanding the use of the 4Ps Plus screening tool to include more medical providers, more visiting nurses, more in-home partners using this with pregnant women so that we can hope to see more informed pregnancies so that we can reduce the number of children being born with substances in their system. If the use of the 4Ps Plus screening tool is interesting to anyone hearing this message, please contact me. My contact information is on our next slide. And we would love to provide training of the 4Ps Plus screening tool along with the brief intervention I am concerned. It is important to note that the 4Ps Plus is a billable service and the administration of the tool as well as the intervention. I will also be sharing information on the Parents Toolkit that was developed by Dr. Chasnoff for all parents and all children, biological, adoptive, foster, whatever shape or form that their family exists, who are raising children affected by prenatal exposure to substances of abuse, as well as for professionals who provide services to pregnant and parenting women and their children. The common thread of all families is that they're dealing with the consequences of alcohol or drug use during pregnancy. The Parents Toolkit is a web-based format that has brief videos of Dr. Chasnoff talking about different areas or opportunities for growth and learning around working with our littles, as well as brief papers and other research around the impacts of substance use during pregnancy. That Parent Toolkit website will be shared statewide. Additionally, the Family Resiliency Program, we will share a PSA video developed by the Waterloo Family Resiliency Program that details the referral process and the services and treatment planning they're doing. If you're interested in partnering with Iowa Children's Justice to stand up a family resiliency program in Iowa, specifically Western Iowa, please feel free to contact me. And we would love to talk more about what that could look like for your agency. We are all here with a shared goal that we want Iowa's children to get started off on the healthiest first step. So it's critical that our messaging around alcohol and other substances during the prenatal period impacts the development of children. And through information and awareness, we hope to assist women of childbearing age and or pregnant women to make the most informed decisions. When we incorporate the work of the 4Ps Plus into our work, I believe that we can achieve the goals that we all share. With that, I just want to say thank you very much for this opportunity to speak with you today. Here is my contact information. I welcome any and all questions about how a partnership with Iowa Children's Justice can assist us in decreasing the number of Iowa children who are born exposed to alcohol or other substances. Thank you so much for listening to this, and I look forward to hearing from you.